what's going on there within the orbit. If you remember, there are, um, there are a lot of bones, actually 7 bones that make up this space. And it is not really square, but it has 4 walls. It has a lateral wall, and that is made up of the cheekbone sarcoma. And it has a portion of that also relationship to the zygomatic process of the sarcoma and the frontal process of the sarcoma. So the frontal bone does play a little bit of a role with the zygomatic process. The sphenoid bone, in particular the greater wing, remember this is a bone that you look down at it, it's actually pyramidal shaped. It has 3 surfaces that you can see in relationship to the sphenoid bone greater wing, and that is one within the confines of the lateral wall of the orbit, but also in the lateral surface of the skull and also in the middle cranial fossa. The roof is primarily frontal bone, but there are some areas associated with the sphenoid bone, in particular this little stingray-shaped process referred to as the lesser wing. And then we have the medial wall, which is for the most part maxilla. Primarily, the maxilla also has a process that comes up that articulates not only the nasal bones on their lateral aspect, but also the frontal bone in relationship to that really glabellar region, and that is the frontal process of the maxilla. There's also this bone that's its sole purpose is to provide structural support for a duct, and that duct is the nasolacrimal canal, and that's the lacrimal bone. Then we have the ethmoid bone. The ethmoid bone also can be seen from a variety of different perspectives. One, it can be seen in the anterior cranial fossa, in the middle of the anterior cranial fossa, with its perpendicular plate extending into the anterior cranial fossa as what we refer to as the crista galla, but also within the portion of the orbit, there's a very thin portion of the ethmoid bone that is on its lateral surface, and that is referred to as the paper plate of the lamina caprese. Once again, the sphenoid bone, the lesser wing, comes in close to that medial wall, so that participates in that. And then this real tiny process from the palatine bone that extends all the way up into an area, really it's just inside the posterior aspect of the inferior orbital fissure, and that's called the palatine process, or the orbital process of the palatine bone. Then in the floor, the bones that are making up the floor of the orbit are primarily zygoma, maxilla, and palatine bone. Okay, so these are the bones that make up this region. Let's look at them from that perspective. Here, on the image. So once again, here we've got sphenoid over here. This is the greater wing. And over here we've got the lesser wing. You can actually see a small portion of this palatine orbital process right here. This is the palatine bone right here. In this particular view, we've got the zygoma. And we've got the lacrimal bone. And we've got the maxilla. Over here. We don't see the ethmoid bone from this perspective. We do see some of the foramina. We'll look at those again in just a minute. But we see these bones here. Actually, we see five of the 7 bones that make up the orbit. If we look here now in the medial view, once again these things are on.
Dr. Landers,
Yes.
the picture that you provided it has what you labeled as the lacrimal, labeled as ethmoid on here, on the slides.
Well, okay, I'm a little bit high. Okay, right here, because here's the nasolacrimal canal.
So then posterior to that, would that be the?
Just
the
starting to
ethmoid?
see it, but not really a clear enough view, okay? We'll see it over here in the next slide. Okay, so there's somewhat of a merging of the ethmoid bone, the anterior portion of it, but really, here's the ethmoid bone over here. You can see this kind of grayish cast is because it's so thin. That's the purple, that's the lamina papricia. The ethmoid bone has two little foramen in here that we'll talk about in a second. And these are the anterior and posterior ethmoidal foramen. Okay. This was supposed, this little red pointer should be over here. It's the optic canal, and this yellow pointer should be over here. This is the inferior orbital fissure, okay? So we have these openings, we have these 7 bones that make up this region. Sitting below the floor of the orbit is a air sinus, one of the larger air sinuses called maxillary sinus, and it's important to us for a few reasons, one of which, dentition, in particular posterior dentition, the roots of that dentition, like first molar, possibly second molar, possibly even second premolar, the roots actually extend into the sinus, and that can be related to dental pain in regards to things like sinusitis, absolute sinus inflammation of that member.
Would you be able to draw the border of the ethmoid to understand where the ethmoid ends and the maxilla
Okay.
begins, and then I don't understand where the lacrimal comes in right now.
Okay, now here's the lacrimal bone. Here's the ethmoid bone. This is its superior border. And this is the maxilla over here. This is the frontal over here. And then we've got zygoma over here. Does that help?
Yes.
Okay.
And so that inferior orbital fissure, you have 2 arrows, that left one.
Forget the long arrow that is actually part of the slide,
Oh,
because it's distorted. For some reason, the transfer in this program, so it was distorted. So the arrows that I drew here, okay, these are the ones that are pointing to the fissure, and this is the one that's pointing to the orbital, the optic frame, I'm saying. So, from the perspective of what's going through these foramen, okay, which is something that group culture is responsible for, what travels through the inferior orbital fissure? Inferior orbital fissure. Anything we've talked about in the past?
A portion of the deep petrosal nerve,
Which
or
nerve?
no, deep petrosal,
Okay, and the greater petrosal branches are carried how? Within what nerve trunk? Infraorbital branch is the maxillary division, the trigeminal. Okay. What about its anterior and posterior ethmoidal foramen? What's being traveled through it? What cranial nerve gives rise to the nerves that are actually leaving the orbit and going into the nasal
going back to the inferior orbital fissure, on the packet that you handed out, it has the maxillary nerve V2, but then it also has the structures. What is that referring to? So it says zygomatic nerve, orbital nerves, orbital nerve.
Because it's bringing in those zygomatic branch is also a branch of the maxillary division, which travels in the inferior orbital fissure with the infraorbital trunk.
Okay. And it doesn't have anything listed about the greater petrosal, so are we supposed to associate that with a different foramen, or?
We'll get there.
Okay.
Thank you.
Okay, so the foramen in the lateral wall zygomatic orbital foramen. So this is where the zygomatic branch goes, and it gives off two subbranches. Do you remember what those subbranches were? What are the branches of the zygomatic branch of the maxillary division? Zygomatic or temporal, zygomatic facial and temporal. Okay. And they're going to go through the zygoma and out to the structure surface of the face and the lateral scalp. We'll also talk about another branch that actually does not have anything to do with innervation of skin, but it is carrying the greater petrosal branches actually up to its cousin, the inferior, the lacrimal branch of V1, and taking it to the lacrimal gland. We'll see that. The roof, there is a supraorbital notch and supraorbital or supraorbital foramen. Depends upon whether it's the opening is completely closed or open. What travels through there? What travels through the supraorbital notch or foramen? Right.
That was a question I had, because last night I was in the lab, and most of the ones I looked at, it's not a foramen, it's just a notch. So if there's something important that's supposed to travel through there, and it's closed, what do? Does it just work its way around?
Well, it's not, what it is not, it's not totally closed, okay? There's something coming through there, so it's either a foramen that has, is completely surrounding the opening. The bone is completely surrounding the opening, or it is a notch where the lower portion of that opening is open itself, okay?
It's really, really small, maybe?
It's just a groove, okay? It's just a groove. So if it's completely closed, yeah, if it's completely ossified, that is a problem. But it may have to come out, there may be some type of analog that comes out under the superior orbital rim, as opposed to going through the opening itself. It comes out through the superior orbital rim. What are those nerves branch of? Once again, in relationship to the trigeminal, what are they a branch of? Which division? Okay, V1. And what are they innervating? What's their role? What's their functional role? The lateral corner of the upper eyelid in particular, and the forehead, and actually as far back as what we call the peak of the scalp, called the vertex. And they actually overlap with sensory nerves from the back of the neck, one in particular called the greater occipital. Posteriorly, we have the optic canal. What goes through the optic canal?
Optic nerve.
Optic nerve. Anything else go through there?
Perfusion for the eye.
Ophthalmic artery.
Right, ophthalmic artery, and also a branch of that artery that goes down the center of the nerve, called the central retinal artery. That's the main arterial blood supply to the retina itself. What about superior orbital fissure? What are the things that go through superior orbital fissure? 3, 4, 6 feet 1. Okay, what else? Anything else? Ophthalmic vein, right. Okay. Medially, anterior ethmoidal foramen, we just talked about that, posterior ethmoidal foramen. These are branches of the nasociliary portion of the first division of trigeminal. Also, the opening at the corner where the maxilla and the ethmoid bone kind of surround it, this nasolacrimal canal. What goes through the nasolacrimal canal? What other organ do we spoken about that has the term lacrimal associated? Lacrimal gland, what is the lacrimal gland? What does it do in the eye?
Tearing.
Tears, okay. So the tears drain through that, where do they go? We'll talk about this in the coming lecture. Where do they go?
Where do the tears go?
Where do the tears go?
Down the face, I suppose.
Okay. Well, that's if you're really sad that day. Okay, you're really sad. They drain through that canal opens into the nasal cavity.
Oh, this is just the standard wash that's going by all the time. Okay.
Okay. All right. So here we are in the middle cranial fossa. Here's the Christgala.
Wait, just to double check, so the answer to that question of what goes through the nasolacrimal canal was just tears?
That's it. That's it. That's it. It's a pretty good size opening for tears, isn't it? Okay. So hopefully you don't get to that point while you're in dental school, but there are points where you'll be close. And then next to the Christgala in the ethmoid bone itself, this is the cribriform plate. What goes through the cribriform plate?
Olfactory bulb.
The olfactory bulb sits on top of it. What goes into the olfactory bulb from below? Olfactory nerves. Okay. Here we've got the optic canal. And here we've got this superior orbital fissure. And then we've got this round frame back here called foramen rotunda. What passes through the foramen rotunda? B2.
Is there another function of the Christgala besides like separating the cribriform?
It's just the extension of the middle of the ethmoid bone, which helps to make up the bony nasal septum. We'll talk about that again when we get into the nasal cavity. But it's just the peak of the perpendicular plate of the ethmoid bone, which helps to make the upper portion of the nasal septum. Okay. All right, so the primary structure that lives in here, besides all of these nerves that are passing through the orbit, is the globe of the eye, the eyeball. And this is attached to the optic nerve, and also what is attached to the eyeball are the muscles that help the eyeball move within the confines of the orbit, which we refer to as extraocular muscles. They move the globe of the eye, they move this big eyeball. Also in there are lacrimal gland, which is in the upper lateral corner of the orbit, and those that is the gland that produces the tears. Okay? And its ducts basically just open right over the surface of the cornea, which we'll talk about in just a second, which is part of the outer coat of the eye. When we first go in, we'll be doing this dissection soon so that you can see it next week. We've got here's the Christgala, and here's the cribriform plate over here and over here. Okay, and so this is the view we hope to get when we dissect in here and use a bone saw to get over the orbit. Here's the optic nerve. here is the orbit and everything within it that is surrounded by this, this tissue, which is called periorbital dura. So this periorbital dura surrounds everything really that's within the confines of the orbit itself. From a developmental perspective, I don't think Dr. Prideaux in his lecture talks about the development of the eye here, but the eye's got to get into this region of the skull before this region of the skull starts to oscillate. Otherwise, it's going to get trapped in the middle cranial fossa. The eye and the other structures going into the orbit are actually evaginations off of the surface of the developing brain, what we call a secondary vesicle. So they are actually evaginations off of the surface of that are going to pass into this region we refer to as the orbit. So this is what we see when we first go in there, and then we have to dissect through it to see the structures we're going to be talking about this morning. So the outer layer is this layer that is called the sclera, and the sclera is a very dense fibrous tunic, a covering that envelops basically 5/6 of the eyeball. Okay, basically it surrounds 5/6 of the eyeball. The last sixth of the covering is in the front of the eyeball, and this is a transparent. Surface that's referred to as the cornea. But the scleral corneal surface is basically unified as one. And it will contain everything else within the confines of the eye, particularly the eyeball. Okay. So the cornea, yes, Brian?
The dura that protects the eye, is it more or less the same as like the dura mater or pupil, or is it not like that?
It's probably a little bit thinner,
Okay.
but it is an extension of dura mater, okay? So the cornea is responsible for refraction of light. Actually, most of the refraction of the light that takes place for you on a given basis when things are actually away, or farther away from your face, and what I would say, farther away from your face, they're probably at least 3 to 5 feet away from your face. It is refracting the light into the eye through this region we'll talk about in a minute, the lens. And the lens is taking that refracted light and trying to focus it on an area we'll talk about in the surface of the retina, which is a little bit more lateral in position than the optic nerve, and that's called the macula. And inside the macula is an area of highest visual, what we call highest visual acuity, which is called focus centralis. Okay. So most of things that are away from us, or at least far enough away from us, they talk about when you go and you have an eye test, they basically test you with a standard that's called 20/20, where they have you in a position that's approximately 20 feet away from the objects you're trying to read, and so you're standing 20 feet away from them, and you're able to read objects or certain letters at a given line. It's usually about 10 lines. If you could read the 10th line, you're probably as good as any vertebrate out there. But here you have what they consider to be 20 vision. Okay. So that is what the role of the cornea is to refract light. Now, there's a deeper layer in here that is deep to the outer sclera, and it is deep to the cornea as well, and this is called the choroid layer. The term choroid actually means something that's colored. Okay. So the choroid layer consists of blood vessels, connective tissue, and pigmented cells. Okay, the deepest layer is actually the pigmented cells, and they actually are on the deep side of the retinal surface itself. Okay. if you dissect an eye, or an eyeball, when you go inside, the retinal surface actually looks black. Okay? And this black surface is actually the deep layer behind it that we refer to as being the choroid layer. Okay? We'll talk about, from a general perspective, we'll talk about the rods and code sensors in just a second. But that kind of makes sense. What do we know about light surfaces and dark surfaces in relationship to the absorption of light? Dark surfaces absorb light, okay, and usually lighter surfaces reflect light from other surfaces, okay? That's why recently I had these two cataract procedures, because my lenses were starting to get thicker, and as light objects that were emitting light came closer to me, they were basically reflecting off of my lenses and making it more difficult for me to see. So, for example, night driving is harder with somebody that has a cataract lens as opposed to driving in daylight. All right, so that choroid layer, we're gonna look at it on a schematic in a minute, but then the inner layer is referred to as the retina. This is a sensory surface, okay? And light has to pass through the cornea, through this little central area referred to as the pupil, and the pupil is actually out in front of the lens, and it has to pass through the lens, and it has to be focused onto the retinal surface. Okay, but this is the sensory surface. This is where the photoreceptors are, and these photoreceptors are referred to as rods and cones. But before this happens, we have to control the amount of light that's going in through the pupil, and is being focused on the back surface or on this retinal surface. Now, there's some areas inside that we'll talk about in a sec, that is referred to as the uvea. The uvea consists of the iris of the eye, which is really the pigmented portion of the eye. In the iris of the eye are two types of muscles. There's a radial muscle that's like spokes on a wheel, and there's a circular muscle that's like a constrictor, like a valve. Okay. So those muscles are within the confines of the iris, also the pigmentation that gives you your characteristic eye color. They say that eye color and hair color are somewhat closely linked in terms of genetic transmission. We all usually, at the beginning of life, or our neonatal life, our eyes are actually a lot lighter than they will possibly be as we get older and go into childhood years and into adulthood. Also, there's an area in there that is attached to, comes up a lot laterally on the side of the iris, and this is called the ciliary body. And the ciliary body is actually a smooth muscle that controls the lens, controls the thickness of the lens. And then also this choroid layer that is just deep to the retinal surface is also part of this area called the uvea. So sometimes when we have, you've seen people with conjunctivitis where the outer surface of the eye, the whites of the eye are very inflamed and look very inflamed, but really in the center where the iris is and the ciliary body surrounding the lenses, the choroid are, sometimes we have a condition that's called uveitis. It's more in the center of the eye than peripheral to the pupil and the whites of the eye. All right, so this pupil is important because it controls light. It controls light. Do we need the pupil open wider during when there's a lot of light in the room, or do we need it closed? Both. Okay. So usually the pupils, if you look at yourself in a mirror, okay, you usually see that your pupils are somewhat smaller and that they are centered. Okay. and they're not, you don't see a very large opening, or a dilated opening. So that's controlled parasympathetically, okay? That's what we would consider to be a homeostatic type activity, is normal pupillary diameter. Now, this is controlled through parasympathetic innervation to a muscle that's referred to as the constrictor pupil, or the constrictor pupillae. And this is innervated by what cranial nerve? This is a parasympathetic innervation, the constrictor of the pupil, yes. Ocular motor. Remember, the ocular motor is the highest parasympathetic nerve, okay? And it sends fibers, we'll talk about, to a body called the ciliary body. And this actually has innervation of this, not only the constrictor of the pupil, but also of the ciliary body that surrounds the lens. So, dilation is a sympathetic function, okay? Dilation is a sympathetic function, okay? And that's when we are entering into an area where there isn't as much light, okay? Basically, a dark room, okay? If you could see yourself in a room that's completely dark, or see your face completely dark, you would see that your pupils are dilated as much as they possibly can be, okay? So, pupillary dilation is controlled by the sympathetic nervous system. Where do the sympathetic nervous system, how does that get its postganglionics in this area? Where do they travel now, once again? Artery. So what artery would bring these sympathetic fibers into the orbit? Okay, what's the large artery that supplies the brain? Which branch? Internal carotid, okay. What is a branch of the internal carotid artery that enters into the orbit? Okay, ophthalmic, okay, so those postganglionic fibers are going to be carried into the orbit by this ophthalmic branch of the internal carotid artery. And they are going to then come forward to the iris of the eye, and they are going to innervate radial muscles that when they contract, they pull 360 degrees around the center of the pupil, and they dilate the pupil of the eye. Now, the pigment in the pupil is important. Okay, the pigmented color of the pupil is important because that controls light scatter. That's then the light's going to be more uniform as it goes through the pupil and goes through the lens of the eye. Now, I told you that the cornea is there to do most of the refraction of light. But what happens when things now are close to us, close to our face, okay? Or we're reading a book, or we're reading a computer screen, and we're now holding it up here, something is coming closer, person, place, or thing, it's coming closer to us, okay? How is the cornea going to get the light? Okay. So it's going to, if I'm looking at my hands, most of the light is what? It's hitting the back of my hands. It's hitting the dorsum of my hand. Okay? Whatever light is coming in is being refracted by the borders of the cornea through the lens, and then the lens is changing its shape to get as much light or much of the visual axis on the retinal surface. Okay? So the lens is a finite type of device for the focusing of light on the retinal surface. And it can either expand or contract depending upon what the light waves are basically telling the nervous system in the we're hitting the retinal surface and controlling things like the pupil, okay? So typically pupils are somewhat constricted, when under normal light conditions. They will actually be probably a little bit less constricted than not. And as things come closer, they are too trying to get as much light through a small opening as they can and get it through the lens of the eye. And the lens of the eye is going to change its shape based upon its ability to focus whatever light from this image that is coming in, so that we can make out what this image is that we're seeing. So the ciliary body is a muscle. It's a smooth muscle ring around the surface of the lens of the eye, and it has little tiny thin ligaments that interconnect to the outer border of the lens of the eye. And when it is relaxed, when there is enough light, and we can get corneal refraction. We get corneal refraction, then we usually have enough light to see the image that's in front of us. But as images come closer to us, we have to get whatever light is surrounding that image to see its shape, possibly to see its color, its size, and we have to refract that light even more. So that's what the role of the lens is. So the ciliary body starts out basically as a large circular ring of smooth muscle attached by these tiny ligaments, they're called zonual ligaments, to the outer surface of the lens. And if the nervous system is saying we've got to do something, change the shape of the lens in order to see more clearly this image that is so close to us, could be just words on a page. Okay? We're going to have to change the shape of the lens. We're going to have to, typically it's a biconvex surface. We're going to have to increase its convexity. We're going to have to make it thicker. So we're going to have to go from a lens that's maybe, like this, to a lens that's like this, okay? To bend those light waves onto the area of highest focus in the retina. So that process where we have pupillary constriction, where we have a changing of the dimension of the lens, is referred to as accommodation of near vision. Okay? Accommodation for near vision. When the lens has to get thicker in order to see more clearly things that are closer to us. So that's why on an eye chart, they start out with very large letters that you should be able to see way out there, but they can also determine the effectiveness of your lens as they say, okay, read line 10, where you've got, at 20 feet, you've got a letter that's maybe 2 millimeters high. So by thickening the lens, we make it a stronger biconcave lens, and we can focus these light waves on the retina, yes.
So because of the change in the lens, that's why when we have objects like super close, we tend to see it blurred, or like double vision.
When we, what?
When we have something near, and like that's why we see it kind of blurred, because the lens is changing.
It'll depend upon the health of your lens. Okay, there's a process, there's a thing called astigmatism, okay, where the lens has difficulty focusing. The other thing is that we'll talk about is that our visual systems are what we call stereoscopic. In other words, both eyes have to be able to focus on the object simultaneously. If one eye cannot focus on the objects with the other eye, then it will appear blurred or double.
What did you call the ligaments of this area?
Zonule, Z-O-N-U-L-E, yes.
For substances that cause your eyes to dilate, such as the eye drops, when you get your eye exam, they're dilating your pupils. Do those target the nervous system, or is it blood flow, or how does that work?
Well, they theoretically, because they're vasoactive agents, they can have an effect on both, but primarily what they are doing is they are anesthetizing the constrictors, okay? They are a parasympathetic inhibitor. So they basically shut down the constrictor muscle so that the dilator muscle can take hold, okay? And so that causes the pupil then to open wider, so now the ophthalmologist has this large window to look through. So that's what's happening there. I've had a lot of that lately, it's annoying. All right, let me see if I can get this back up. Good, all right. Communication.
Should we take a break now?
What?
Should we take a break now? It's taken.
It's probably a good idea. Shoot, coat on the sclerocorneal surface, we have this middle layer, which essentially is a highly vascular layer, both from the standpoint of supplying the sclera, but also from the standpoint of supplying the retinal surfaces as well. And then we have this intersensory layer, referred to as the retina, okay? As we go inside, we've got this uvea area, which consists of the pupil, or the iris, the ciliary body, and the choroid. We have control of this opening, both autonomically, either via a parasympathetic aspect for constriction of the pupil, or a sympathetic aspect for dilation of the pupil. Okay? Ciliary body is this smooth muscle area. It also has an area where it produces a fluid that not flows over the outside of the cornea like tears, but flows on the inside of the lens and the pupil. And this is what's referred to as an aqueous liquid, or an aqueous humor. Okay? Behind the lens is a thicker liquid, which primarily gets its thickness from a molecular agent called hyaluronic acid, and this is like a gel-like consistency. This is called vitreous humor. It's about 90% water, but it also has the hyaluronic acid in it, which gives it a little bit more body as a fluid. And this helps to keep the inner surface of the retinal surface healthy. What happens during age, when things, unfortunately, the biggest problem with aging is that we don't replace cells as often. We have a tendency to dehydrate a little bit faster, and in this case, when the vitreous dehydrates, it then pulls in on the surface of the retina and can detach it from the posterior wall of the eyeball. All right, so here's the eyeball. Okay, so with our sclera, in this front portion, cornea, and then we have this anterior chamber behind the cornea. Let's see if I can get this one right now. This anterior chamber is filled with a clear fluid. It's actually also produced by an aspect of the ciliary body. That's why when they talk about it more from that standpoint as opposed to just a muscle. Here we have the pupil. And here we have the iris, which is a pigmented layer, okay? Now, within the confines of the iris, there's going to be, in the center of the iris, there's going to be muscles that are primarily constrictors. So these are the pupillary constrictors. And outside here, we're going to have muscles that are kind of like spokes on a wheel, and these are the dilators. Then we have the lens here in the center, this biconvex lens. And it is interconnected to these smooth muscle entities over here, which are referred to as the ciliary body. It completely encircles the lens, and then these tiny little ligaments here, these are what we refer to as the zonular ligaments. So the lens is very pliable. It's kind of scary. I mean, I've seen, when I was a intern, I saw cataract procedures. It's called a phacoemulsification. They go in there, basically, they emulsify the lens they're going to replace, and then they replace it with something that is it's not living tissue, and it's going to be somewhat fixed focused over the rest of your life, but so I'm somewhat bionic at this point. Fortunately, I haven't had any major bionic parts replaced, but from that standpoint, the lenses are actually fixed focus entities, and they are interconnected then to the ciliary body, but the ciliary body doesn't do much at that point of the lens replacement. So they basically emulsify the old lens and they suck it out and they put it in the new lens. All right, so the ciliary body is here. This region that we would refer to from here to here. This is what we refer to as the uvea. The lens, the choroid, the ciliary body, and the iris. And then we have this surface underneath the sclera, which is a mixture of connective tissue and vascular bed, and some thickened cells, which is referred to as the choroid layer. And then we have the sensory surface here inside of the choroid layer, so on this side, and this is the retina. Okay, so here is a region, this area is where the optic nerve is coming in. It's got an indentation through here. And when the ophthalmologist is looking in here, or your physician's looking in here, they can actually see this area. You can see the central retinal artery and central retinal veins in that area. But interestingly enough, in that area where the optic nerve is coming in and forming what we call here an optic disc, there are no sensory cells. There are no sensory cells. So it's actually sometimes referred to as a blind spot. anything that would hit that area from the standpoint of visual acuity would not create an image. If we go out more lateral here, we have this area over here with this little indentation. And this is actually, if you look at it with an ophthalmic scope, it actually has kind of a yellowish cast to it. So it's called the yellow spot, or the macula lutea. Okay, in the center of that spot is our area of highest visual acuity or focus. So when we want to see things clearly in their entirety, both from the standpoint of not only what they look like from the shape, but what they look like in relationship to the differences in color, contrast, we want to focus right here in this spot. So this is called the central focus point, or the fovea centralis. Now, one of the other things that's kind of interesting is that when we're trying to focus an image, we're trying to get it here on this fovea centralis. Okay? And we're trying to direct it down through the center of the pupil onto the fovea centralis. And this is what we refer to as the visual axis. However, the optic nerve actually enters into the orbit from a position that is more medial to the this fovea centralis, because the optic nerve is here. So if we would then draw an axis from the optic nerve out, that would basically, if all of the muscles in the eye were relaxed, okay, at the same time, the pupil of the eye would actually be directed more in this direction, and this is what we refer to as the orbital axis. So here's kind of the issue. Okay, we're going to look at the muscles in a minute. You've got the eyeball sitting in the globe of the eye, really in relationship to this large nerve running down the center of the retina, but more medially directed, so that the eye in its most relaxed position, the pupil would be out lateral. So we are always in a position where we have to manipulate the position of the eye, in particular the area of focus, the pupil, in a position where we can see, and not only where we can see, but where it is at the same time collaborating with the eye on the opposite side. Okay? So what we refer to as stereoscopic or bioptical vision. Okay? Otherwise, we can't see things clearly. So the muscles are always in a situation where they have to be working. Okay? So in particular, when you are doing things, for example, you're doing a lot of reading, you're doing a lot of computer work, okay? You're looking at a lot of things that are right in front of you. We actually have to move the eyeball to the center, okay? We have to pull it medial on each side, okay? So if you're doing this all day long, those muscles get tired and fatigued, okay? So also the lens, because it's ciliary muscle, if things are closer to you, those muscles are going to be put in a position where this constrictor is coming closer to the lens and allowing it to expand, and they are becoming fatigued as well. So eye fatigue is in relationship to, not, light strain, but the light is causing an issue. But it's in relationship to straining the muscles over a long period of time. It's kind of like, these muscles aren't really aerobic, okay, per se. Okay? So they really are more anaerobic, and so they need a lot of glucose to go do their job. All right. So here's kind of another schematic overview where we're looking through through the lens of the eye, over here. And we're trying to focus light over here in the center on the macula, okay? We've got the retinal surface here. Just deep to it, we have a choroid surface. Back here. And then outside of this, we've got the sclera. Okay, so this choroid layer at its deepest point has cells that actually create a darkening of the surface behind the retinal cells, okay? Behind the retinal cells. And this is called retinal pigmented epithelium, okay, in here, this layer in here. We've got these sensory cells in here that we'll talk about in a minute. These are called rods and cones, okay? Now, the majority of sensory cells on the surface of the retina are rods, okay? They are for making out shapes. They are also for dark vision, okay? We can stimulate more rods if we change the character of light, okay? If we go from from the ultraviolet rays into rays which are infrared, we actually, in the dark, we see a lot better if there is a red light cast, or red lighting in the cast. That's what they do. They do that in submarines, or in any area, for example, a dark room, okay, where you want to see, but you don't really want to get high frequency waves of light on your film, or get this energy going through the hull of the ship, so that some destroyer up there can find you with their sonar. Okay? So this dark surface is important once again because it is going to absorb the light waves. So what is going to happen here is that these waves of light here, the optic nerve is going to be here and it's going to lead, but all of the cells that are deeper to it, these being the rods and these being the cones, okay? The cones are really only in one place. They're in the fovea. They're in the fovea centralis. They are not on the rest of the retinal surface. So in order to see things from their greatest extent, not only from their shape and size, but also from the color that they demonstrate, you have to focus on the fovea centralis. Okay? However, okay, where is the light affecting the sensory cells? It's back here. So the choroid layer is absorbing the light because it's dark, and it is then stimulating the rods and cones to be able to transmit this light through. There's a lot of cells in here. There's cells called bipolar, there's cells called amacrine. There's cells that kind of do a little bit more of what we call lateralization, okay? In other words, they reduce extraneous energy and extraneous sensory energy to try and get a greater visual outcome, okay? And so then from the rods and cones, through bipolar cells, through amacrine cells, these are the ganglionic cells of the optic nerve, and they will transmit their information down the optic nerve, into the optic tract, into the what's called lateral geniculate body, and then which is a thalamic nucleus, and then send it to the occipital lobe of the cerebral cortex. All right. We looked at some of this before. So how do we move this globe of the eye around? Okay, we move it around with muscles. These are skeletal muscles. Okay, where did these skeletal muscles come from? Did they come from branchial arches? Do the extraocular muscles come from branchial arches? mean, this is the head.
Would it not be the same as the facial muscle expression or different origin?
Well, we spoke about this, what kind of skeletal muscle do we have? We have, in the case of the head, we have muscle that came from branchial arches, what we call branchiomeric. It's no different than skeletal muscle anyplace else, other than where it came from. And we only find that in the head. But what's the other type of origin of skeletal muscle? Somites.
Somatic? Yeah.
Somites. So these extraocular muscles actually come from somites. They come from what are referred to as pre-otic somites, okay? Pre-otic somites. And they're still skeletal muscles, just like other skeletal muscles from a histologic perspective, but their point of development in relationship to the head is not branchiomeric, not coming from pharyngeal arches or branchial arches. It is somatotypic. It's coming from somites, just like the rest of the muscles of the body. In the head, another group of muscles we'll talk about in the oral cavity are the muscles of the tongue. Those also come from somites called preoccipital somites, but these are preotic somites that create these muscles. Okay. So we had looked at this image before. Okay. And we saw what we talked about a little bit earlier, branches of the trigeminal first division that comes through the orbit. Remember, what you gotta remember, you wanna know where V1 branches are. V1 branches are coming into the orbit to join the ophthalmic division, okay? And they are all, from the perspective of the trigeminal nerve, they are all general sensory, GSA. They're all general sensory. Now, in saying that, I told you, remember we've got nerve trunks that carry other entities in them from other cranial nerves. But these nerves from this first division are all general sensory. So we have one over here, which is going to actually pass out of the orbit over the top. Over the top of the lacrimal gland and come out here. And this is what we refer to as the lacrimal branch. Then we have the largest trunk, which is coming back here, and this is the frontal nerve. And this is coming back here. This back here, where these two branches are coming from, this is V1. And then over medially, from a deeper perspective, we have these nerve branches here that are coming more medial and going actually into the nasal cavity. And then one of them actually goes out here underneath this trochlea, and these are nasociliary. Okay. So they're traveling through the orbit. Now remember, they're sensory. They are receiving information. Okay? Even though you see in a lot of textbooks they say, well, these are the branches. Well, yes, they're the branches, but they're not carrying information out. These are carrying information in. These are sensory branches. Okay? So if somebody hits you in the forehead with a hammer, you feel the pain, and that painful stimuli is brought into your brain. Okay? If not, it's probably because they did so much damage to the nerve ending that you don't feel anything. Okay, so these are in association with certain extraocular muscles that we see here that are attached to the globe of the eye. We've got, we've got this one here. This is a muscle that attaches to the upper eyelid. This is called levator palpebrae superioris. Then we've got this one over here on the side. This is called the lateral rectus. Rectum just means straight. We've got this muscle over here that has an interesting relationship with this structure over here that is referred to as a pulley or a trochlea. And this muscle is referred to as the superior oblique. Now, there's a couple of other muscles that we could kind of make out here that are a little bit deeper. This muscle here is deep to the superior oblique, that's the medial rectus. And then there is a muscle that is deep to the levator palpebrae called the superior rectus. Okay, so we can see 5 of the muscles here. We can't see the other 2 of the 7. We can't see inferior oblique from this perspective because it's down below the eyeball, and we can't see inferior rectus because it's down below the eyeball. But these are muscles associated with being able to move the globe of the eye. Okay? And once again, if you look at the muscles are in line with the optic nerve. So in order to get that eyeball looking straight forward, there has to be some synergistic activity with these muscles in order to move the pupil to the center, okay? I don't know, some people can actually, I should have brought that at my desk. It's a lady that demonstrated an exophthalmic type perspective where she literally learned control of opening her eyelids so wide and pushing her eyeballs out. Really weird. Okay? Really weird. And she actually practiced that over the course of her life.
Do you mind outlining the trochlea?
Trochlea?
Yeah.
Okay, that is right here.
Okay, thank you.
Okay. And then the nerve that innervates the superior oblique comes in here too. That's cranial nerve 4. And cranial nerve 4 gets its name from the muscle that goes through the trochlea. And that is this nerve here. And that's typical, we'll see in the lab how it comes into this muscle over the top edge. And this is referred to as cranial nerve 4, or the trochlea. They do show here, it's harder to see actually in the cadaver than any place else. They do show this nerve going into the lateral rectus, and this is the abducent, 6th cranial nerve. So the lateral rectus is innervated by the 6th cranial nerve, the abducent. Why? Because abduction is moving the eye out laterally, away from the midline, okay, of the eyeball. And the superior oblique is a muscle that actually, we have to show you in a list that I've created for you, moves your field of vision or your eyeball so that your pupil is pulled upward and downward and out, so that you're looking down here in the corner. Okay, you're not looking over here, you're looking here. More temporally and more inferiorly. So, other than those 2 innervations, what innervates all the rest of these muscles? Oculomotor. Now, the levator palpebrae is an interesting muscle, because as the ophthalmic artery, and in this illustration you see all these ophthalmic arterial branches coming in here too. How does that artery get into the orbit? How does it get into the orbit? What opening does it come from?
Which one?
Ophthalmic arteries.
The superior. Oh, the artery.
How about the
You
optic
okay
canal?
now?
And it's
What
the
vessel
ophthalmic
goes
vein
through the
that
superior orbital fluid?
Is it the ophthalmic vein?
So this muscle also receives sympathetic postganglionics that hop off of the ophthalmic artery. They actually join some of these nasociliary branches and have an effect to go to the front of the scleral surface and go through the scleral surface and into the area of the uvea, into the iris of the eye, and innervate the dilator muscles. But some off of the top of the ophthalmic arterial branches go into this levator palpebrae superioris. Okay? Why does that make sense? What is the character or the functional characteristic that's always, when somebody says sympathetic nervous system, what's the function of the sympathetic nervous system? What do you say? What do you usually say? Fight or flight. Okay? Really, it's stress. Okay? It's stress. Okay? But, you know, I've said this to you several times. You know, when I was growing up, there were a lot more B-movies than today. I mean, now we have all of this graphic illustration that they can use. I mean, it absolutely amazes me. But then the actor had to demonstrate everything that they were feeling, okay? Including things like fear, you know? So when you are in fear, or another thing, when you are in darkness, which is your primary autonomic stress on a daily basis, okay, you have to pull your upper eyelid up as high as it can go. So there's a group of small, smooth muscles inside of this skeletal muscle, referred to as the levator palpebrae superioris, called the muscles of Mueller. And the muscles of Mueller are smooth muscles that give that little extra pull, the upper eyelid. And so when somebody is really, you know, frightened, they pull their eyelids up as high as they can, you know? So this is a sympathetic reaction of this muscle through these muscles of Mueller. Mueller also did a lot of anatomy. I don't know if I spelled it right. My spelling is worse happening. Okay, so these are muscles that we can see here. We can also see here on this side of the levator palpebrae. Here's levator palpebrae. Here, this is the superior rectus. Okay, recta just means a straight muscle. Okay. Now, how are these muscles attached? I mean, they have to attach something in order to provide some type of movement. If we look at here, you know, with the nerves kind of taken out of play, okay, here, here's levator palpebrae. Over here. But then here's superior rectus, lateral rectus, medial rectus, superior oblique over here. They all come from a point of attachment back here that kind of surrounds the optic nerve in the back. And surrounds these muscles and anchors them to the back of the orbital bone, okay? And this is called the ligament of Zinn. The ligament of Zinn, bless you. Now in the front, these muscles actually come around a common attachment here on the surface of the eyeball in relationship to one another. And this is a connective tissue area that helps to anchor the front of the eyeball to the anterior rim of the orbit. And this is referred to as kind of a capsule ligament. These are called Tenon's capsule. Okay, so the eyeball is anchored in the front. The Tenon's capsule doesn't mean that it can't move, but we don't want it to, you know, be pulled back too far, or out, be pushed out. So this is an example. So all of this in here, this is Tanon's capsule. Forget this. This is out of sync. Okay. And here is the muscles as they attach to this area here. They attach in relationship to this little coronal radiation that surrounds the area. Actually, it's a junction between the area of the uvea and the interretinal surface. Okay. So, because it has this kind of serrated border, that's what it's called. It's called the aura serrata. And then back here are the muscles. This is the ligaments of Zinn. Back here,
So this is a posterior view, like from the inside?
this is looking from anterior to posterior. So we're looking, the eyeball's been removed. All we're
Oh,
looking
okay.
at here
Right.
is we're looking into the eye with the eyeball removed, but the points of origin of these 6 muscles, okay, is attached to that ligament of Zinn, surrounds the optic nerve, okay? The eyeball is kind of interesting from the perspective that usually we don't, there's a couple of things. We'll talk about something in the neck called the transverse cruciate ligament, okay? But you usually don't have an articulation of an object on soft tissue. But behind the eyeball, there's actually a lot of space because the eyeball is out here, takes up all the space, but as we taper back, there's kind of this triangular space behind the eyeball, and it's totally filled with a very finite fat, a very highly lubricated or oily fat. And that's what the back of the eyeball articulates with. It articulates with this, what we call periorbital fat. When we go through that periorbital dura to see these structures, we actually, the hardest part is picking away the fat to see the structures themselves. Okay? So that is the ligament of Zinn. That is the point of attachment of everything except this one muscle here, and that one muscle is the inferior oblique. Inferior oblique, when it moves, it allows the eyeball to look up and out. Superior oblique, down and out.
Inferior, it allows to go up.
Up and out,
Superior,
down
down.
and out, yes. All right, so here's a dissection that we did. Okay, so here we've got, here's the lacrimal gland. Over here is here's the cornea. Here's the pupil or the iris. Here you can see back here, this is some of the periorbital fat. Okay, here's the levator palpebrae. It's cut away because we cut away the upper eyelid, so we don't see it attaching to anything. Here is the superior rectus. Here is the medial rectus. Here is the inferior rectus. then here, coming up this way, off of the maxilla, this is the inferior oblique. So all of the other 6 muscles, they get their point of origin from the ligaments of Zinn, the inferior oblique off of the surface of the maxilla, which is helping make up the floor of the oblique.
What about the superior?
Superior oblique is also coming off of the limb. We can't see it here. You can't see it because it's covered up with fat and it's coming in at an angle, a little bit greater angle. Same thing, we don't really see the lateral rectus because of the fat. You can actually see a tiny little attachment here. Okay. All right, so if we look at this list here, we have these muscles, and I've got them listed for you, and what they do and what their innervation is. Okay, but there's basically a formula that is usually used in relationship to describing these. Okay, so the superior oblique, what's it innervated by? Which cranial nerve?
4.
Okay. Okay, superior oblique is innervated by a 4. What's lateral rectus innervated by? 6, okay? So we've got superior oblique sulfate here, and lateral rectus. So SO4, LR6, those are the 2 muscles that are different as far as their innervation. All others by 3. SR6, LR4, all others by 3. And as we go through here, we see this, and we also see this relationship between and this ring is in. Here's the second part of that. Okay. Movement of the globe of the eye needs synergistic activity of the muscles in order to focus. Okay? Or anything gets in the way of that, and we're going to have double vision. Okay, so this is a bilateral process. Have you ever seen an owl? Have you ever watched them as they're looking at their environment? Do you know that an owl its eyes are, for the most part, they're actually fixed in spec. But they can move their head almost at the neck, almost 180 degrees in either direction. The other thing they can do is that they can focus each eye monocularly. In other words, they can focus their left eye on something and their right eye on something else. Okay, so when they're up there flying and looking at the environment and trying to find that little mouse or that rat to take home for lunch, okay, they are scanning a greater visual focal range than we would be capable of doing. Yes.
So according to the table, the superior oblique and the inferior oblique insert at the same position.
Or what?
The
Right.
superior oblique and the inferior oblique. They inserted to the somewhere posterior to superior portion of SCJ. Where is the SCJ?
That's the superior corneal junction on the surface of the eye. That's corona, the oris aurata. Okay,
Show me in
that's
the-
that's where here. Right here. Okay. Scleral corneal junction. Okay.
that slide you just showed us, cause it's not in the slides you posted on Canvas?
It isn't.
No, just the
Okay,
one.
I'll send it to you.
Okay, thank you.
Okay, I'm sorry.
That's okay.
No, it's not. All right, so once again, what are the other cranial nerves that we see in the orbit, okay? The optic nerve is SSA, okay? Special somatic eighth nerve. This is a special sensory nerve that helps us relate as an organism, as an entire organism or soma, to the environment we are in. Allows us to see what's going on and to therefore possibly change our position in our environment in relationship to what we see visually. Okay? So it helps us to see what's going on in our environment. Oculomotor nerve, GSE, buys a GSE because the muscles it innervates come from somites. Okay, that's general somatic efferent. All muscles that come from somites are general somatic efferent. However, it also has GSA components because it has nerve components that are associated with proprioceptive activity. In other words, the nervous system wants to know what the muscles are doing. They want to know the tonus of the muscle. They want to know what the muscle is doing from the standpoint of movement. Okay, so that goes back. It actually goes back to a trigeminal nuclei called the mesencephalic nucleus. Okay. GVE. What's GVE? General visceral efferent, okay. What is it? Parasympathetic. Remember, there are 4 cranial nerves that are parasympathetic. 3, 7, 9, and 10. So this is really the highest cranial nerve in relationship with the craniosacral aspect of the parasympathetic nervous system. The lower portion of the parasympathetic nervous system is down in the pelvis, associated with sacrospinal nerves S2, 3, and 4. Okay. So when we talk about parasympathetic, we say anatomically it's craniosacral. Its role is homeostatic activity, resting heart rate, normal visual acuity, things like that. Trochlear nerve, also GSE because it comes from somites, and GSA does not have any type of relationship autonomically. I just gave a neuro exam to the podiatry students this past week, and one of the questions is in relationship to these nerves, and basically had like, is it 3 only, is it 3, 4, 6, is it none of these, is it V1, general division 1, okay? And not many of them got it because the thing that they didn't look at was that the oculomotor nerve out of trochlear, and also we'll see abducent. The oculomotor is the only one that has an autonomic activity. Okay. So from a muscular standpoint, they have similar components, but not from a functional point. All right, trigeminal nerve. The ophthalmic branches of the trigeminal nerve, the first division, are received in the orbit. Where are the maxillary divisions branches received? Because it's sensory. That's why I say receive. Where is the maxillary nerve receiving its sensory branches? Okay, pterygopalatine fossa. Okay, pterygopalatine fossa. Okay. So the maxillary branches are usually passing lower, we'll see that relationship in a minute. The abducens nerve is the same as the trochlear. GSE, somatotypic musculature, GSA, proprioceptive feedback. The facial nerve is coming through here to innervate what structure? What's that?
Did you say for abducent, what's it in
It is innervating the lateral rectus, okay? But what is the facial nerve innervating? What's that? Lacrimal gland. Yeah. Be bold. Speak. Show us what you know. Okay. So that gets there in an interesting way. All right, we looked at this a few minutes ago. The openings back here. Okay, in relationship to primarily the optic canal. And the superior orbital fissure. Okay, what goes through the optic canal? Anything else? Central retinal branch of the optic nerve. What goes through the superior orbital fissure? 3, 4, 6, and V1, and what else? Okay, so here we see that. Here we see that. Here is the ophthalmic artery. Okay. Here's the optic nerve. And here we have, this is actually V1. This is 6. This is 4. And this is 3. What's this venous mass in here? What's that called? Venous mass. Cavernous sinus. Blood vessel drains in here from the orbit. What blood vessel? It's a thing. No. Well, there is an emissary vein, but not from the orbit. What's the venous drainage of the orbit if the ophthalmic artery was the arteries? What's the venous tributaries coming back from the orbit? What would you call those? Ophthalmic veins?
I have zero confidence in this, really.
Okay. So what's the issue here? What's the issue? What's the problem with veins in that?
No valve?
No valves. Okay. So there's a vessel on the face called the facial vein, and actually it comes into the medial corner of the orbit and called the angular vein, and that actually interconnects one of the venous tributaries from the venous tributaries coming from the orbit going to cavernous sinus. So you can get some type of bacterial infection that's localized in the midface. For example, acne is usually the one that's given the most credit for creating an inflammatory process, a venous inflammatory process called cavernous sinus necrosis. Yes?
What does that say, ophthalmic something artery?
Where is it?
No, what does that say? Sorry.
I think it was just the finishing the ophthalmic, but on 2
Oh,
lines.
okay.
It's like
I'm sorry,
opthal
yeah.
and
Okay, thank you.
All right. So nerves passing through the orbit, branches of the ophthalmic and maxillary divisions, okay, pass through the orbit, okay. As trigeminal branches, what type of nerve components do they carry? GSA, right? trigeminal branches, they carry GSA sensor. What's the only trigeminal division that has a motor branch?
P3.
Great, SVD. All right, so we looked at this before. Here is the ophthalmic branching over here along with the trochlear nerve. Okay, here we see it, McBatter. Here's superior rectus. Here's the frontal branch. Here is the lacrimal gland. Superior oblique, I don't know how that one would be. Here is cranial nerve number 4. Here is the lacrimal branch of V1 right here. I think I'm gonna, because this is happening, just go from PowerPoint on, but, these are the V1 branches, okay? These are all carrying sensory information. Trochlear nerve is a branch that is associated both from a GSE perspective, innervating the superior oblique muscle, but also GSA perspective with proprioceptive fibers. Here's the vascular bed. Here's the ophthalmic artery coming off of the internal carotid as it ascends to the brain. So that is that there. Here coming through the supraorbital fissure. This is the ophthalmic vein.
Is it ophthalmic or ophthalmic? Because
Ophthalmic is really the correct,
on the text it says ophthalmic.
that's what I really want to say. I would accept either. So here is the cavernous sinus. Okay, here is the maxillary division.
Can you also have that picture that you just had up on the
That wasn't in there? Okay, all right, I'll have to look and see what happened to the presentation, okay? I'm sorry. So here is, this is two branches of the maxillary division right here, coming into the superior, the inferior orbital fissure, zygomatic. And infraorbital. Zygomatic comes out lateral here. One of the things it does is goes through an opening here, that's the zygomatical orbital foramen. Okay, so from the standpoint of being a trigeminal division, what kind of components does the maxillary division
Sorry,
carry? Okay, I'll try again.
Dyslexia. I think HGA is like this.
That's called anomia, that's called anomia, losing. Okay, GSA, okay? However, what do we know about the maxillary division of the trigeminal nerve? What other nerve branches are being carried in it to its effective points? What's the other branch of the fission, the higher branch of the fission? Greater petrosal. So wherever a trigeminal nerve ascending fiber is coming, or a sensory fiber is coming from, it is carrying the postganglionic fibers of the greater petrosal branch of the fascia. Okay.
And we'll pick up on this, next week when we, throw the year in, okay? And I'll try, I'll go through this, I'll send you, see what's wrong with the file, and I'll send you the direct file.
Thank you.
And you took the file down from Canvas, right?
Yeah.
Yeah.
It has, it's just missing a few diagrams, everything else is there. Not even in the old.
All right, all right. Okey doke.